Good afternoon, dear colleagues. Thank you for the invitation, Scientific Committee, to discuss about first trimester screening and especially about biochemical screening and in twins. We are using biochemistry screenings more than 30 years, and for that we should be thankful to group of scientists, Kypros Nikolaidis, Professor Kevin Spencer, and Professor Nevex, who evaluate all of these parameters and adjust this methodology. We are successfully using combining tests in twins and is performing according to chorionicity, where for monochorionic twins we are divided for both risk of aneuploidy, and for dichorionic we are calculate for each fetus. And when is a vanishing twin, we don't calculate biochemical markers, we just calculate the risk with maternal age. But also this screening can bring another advantages. We can evaluate risk of premature delivery, we can evaluate risk of preeclampsia or fetal growth restriction, and even to predict the risk of antenatal death. As we know, these molecules, PAPA and beta-HCG, has big influence in placenta and fetus, and PAPA is influence for cells growth, and beta-HCG stimulates synthesis of steroid hormones in corpus luteum and in placenta. As we know, twins pregnancies are increased in last decades, and this is because of advanced mother age and assisted reproductive technology of increasing obesity and polycystic ovarian system. Twins should be considered a high-risk pregnancy because it's a high percentage of different complications, like a prematurity is very high, it's 40–70%, is a high risk of neurodevelopment disorders, especially in monochorionic twins is a 5–25%, and high risk of perinatal death, particularly in monochorionic amniotic twins is 8–42%. According to chorionicity, we can have different management and to expect different complications, especially monochorionic twins have a specific complications like a twin-to-twin transfusion syndrome, like the selective intrauterine growth restriction, TRAPS. Also in monoamniotic should be conjoined twins, cord entanglement, and is a very high risk of miscarriage and premature delivery. But in dichorionic twins, we expect mainly in a mother complications. I want to show our data of study which we performed in 2012–2019. I evaluate 952 twins and I extrapolate 302. 187 was spontaneous and 115 was IVF. All of them passed combined test, and was a statistical significance of differences in age. Women in IVF group were older, and distribution of patients was depending on parameters beta-HCG and PAPA. Very low beta-HCG, lower than 0.5 was in 10%.2. Lower PAPA was in 11.9%. Higher than 2 mom was in beta-HCG was 11.9%, and PAPA higher than 2 mom was in 5% and 6. As was expected, in monochorionic twins, pregnancy lasted on the mean 36 weeks. In dichorionic twins was until 37.5 days. And this differences was statistically significant. Cesarean section was almost similar, was very high, was in spontaneous 58%, and in IVF was 62%. The average of weight in fetuses was different in the group formed on the basis of chorionicity. Median weight of first and second fetus in monochorionic twins was 2,300, and in second 2,275. In dichorionic was a little bit higher, 2,550 and 2,500. Beta HCG mom mean of was not different in spontaneous group and IVF, but PAP-A mom was higher in IVF group, which we know is related with the type of IVF. All our types of IVF was frozen salt embryos. In a group of study from Melbourne, Australia, they also show, they make a comparison between different type of IVF, and the PAP-A lower was in a fresh embryo, and also they make a comparison of fresh embryo and frozen, which was treated by hormones, and was a similar lower. And they conclude that exogenous hormones treatment is a principal cause of reducing PAP-A in assisted reproductive technology. Incidence of antenatal death in a lower PAP-A was very high, was 35.2%, and in lower beta HCG was 27.7%. Data was statistically significant. Preterm delivery was high in monochorionic twins, and we didn't find differences between normal range and higher range of beta HCG PAP-A mom. Lower PAP-A, we didn't find any relation with the lower PAP-A, but because we excluded stillbirths. In some data, authors also find that there is a big relation with the lower PAP-A and preterm delivery. In the group of Nicolaides confirmed that a lower PAP-A and second trimester changes in Doppler can lead to adverse outcomes. They underlined that PAP-A is a protease of insulin growth factors which play a key role in fetus growth and trophoblast invasion of the decidua. However, this proposal of two-step screening is difficult to implement. Conclusions. PAP-A and beta HCG are early informative predictors of outcomes in multiply pregnancies by different modalities of conception. The PAP-A and beta HCG below the references value are related on increased risk of antenatal death. PAP-A and beta HCG value below the references are related to an increased risk of preterm birth. Our recommendation, biochemical prenatal screening with the assessment of PAP-A and beta HCG, which are substances related to the development of the placenta, should be preferred not only to exclude aneuploidies, but also for early diagnosis of possible complications, such as premature birth, antenatal death. The risk group should include multiply pregnancies whose parameters of PAP-A and beta HCG are beyond the references value. Multiply pregnancies require more attention and monitoring due to high risk of adverse outcomes. Therefore, we recommend the evaluation of B-test screening in these pregnancies in first trimester. And as was said yesterday by Professor Bilardos, that an area of NIPT biochemistry screening is still valid. Thank you for your attention.